I'm going to talk about how to care for patients in a culturally sensitive manner, looking at why it's important to think about cultural sensitivity and awareness. 27 million refugees and immigrants currently live in America, and this comprises 10% of the U.S. population. According to the 2008 U.S. Census Bureau reports, minorities now comprise 33% of the U.S. population, and they will be in the majority by 2042. This is already true among 6-year-olds in America. These major demographic shifts lead to increasing ethno-cultural diversity, sending a clear message that healthcare policy and practices must address the needs of minority individuals and their communities. The principles of culturally competent care apply to all patients, but for the purposes of this talk, I'm focusing on the care of refugees and immigrants. Some wonderful images to remind us of the rich diversity amongst our patients. Thinking about some of the challenges facing our refugee and immigrant patients in the clinical encounter, it goes without saying that language barriers are often very difficult for patients, as most clinicians do not speak the language of their patients. Patients may have differences in their values and cultural practices that affect clinical care, and the deficits in cultural competence of providers may also play a role in the care of patients. Here is a good, succinct definition of culturally competent care. It is high-quality care delivered in a culturally sensitive manner. The objectives I want to cover are looking at the levels at which culturally sensitive care occurs and looking at some frameworks that can be used clinically with patients. Levels of care occur at the individual, group practice, and institutional levels. And first looking at the individual level, what counts for patients? 3 main things: good communication, trust, and relationship. To get some idea of what good communication and trust and relationship building look like in clinical practice and what works and what doesn't work, I spent some time talking to the cultural experts at Harborview. The cultural care mediators who work in the House Calls program work as interpreters and also as cultural case mediators. They get referrals from any department in the hospital about patients that providers are concerned about and will provide services to these patients, including house calls, being the interpreter at their appointments, and a variety of other services to remind patients of their appointments and try and figure out systems for these patients who often are having a lot of difficulty with navigating systems in America. I put together some of the ideas that I gathered from meeting with the House Calls cultural case mediators. They felt that it is really important for clinicians to show patience, to allow patients to tell their story, not to be paternalistic, to apologize if you are late for an appointment, and to give patients an idea of how to move on. For example, I recently saw a Spanish-speaking patient in the emergency room. She had been referred to me from the clinic, and I saw her together with one of the Spanish-speaking cultural case mediators. She was feeling suicidal and overwhelmed. She had a history of a lot of abuse in her childhood, which she had never told anybody about. But it had come to the surface, and she was feeling very depressed and overwhelmed and didn't feel like it was worth living any longer. After some time talking to her in the emergency room, I gave her some ideas of how she could try and focus on current issues that were happening in her life and use her energy for that, and that at a later stage we would spend more time talking about her childhood and feelings that were coming up from that stage of her life. She later told the cultural case mediator that these ideas had helped her move forward and move on, and that it wasn't often that she'd been given ideas like this by providers. The cultural case mediators also emphasized how important it is to have some open discussion with patients first, asking them how their families are, how things have been going recently and not just delve into symptoms straight away. In terms of emphasizing working together, they used an example of tuberculosis and how shameful this diagnosis is in certain population groups. They said that it is really important for the provider to emphasize to the patient that it is not their fault that they have got this disease, and they need not feel shameful about it, and that they would work together with them to help with treating the disease and also explaining to family members and other people, if necessary, how the patient might have contracted the disease and what the treatment plan would be. They felt it was really important to have a knowledge of the patient's background to some extent, so that at least the provider could get some idea of where the patient was from and what their cultural values were. And interestingly, they said that it's important in some cultures not to give the patient too much choice. For example, in Ethiopia, it is felt that the doctor should know what is wrong with the patient, and if you give them too much choice in trying to decide how to treat their problem, the patient may feel that you're not a competent doctor and may not trust you at all in your treatment approach. So as we see, it's important to have very good communication, which involves both verbal and nonverbal communication. In terms of verbal communication, it's essential to have a competent interpreter who the patient trusts. This has come up in clinical encounters for me, that patients sometimes will refuse certain interpreters for the clinical interview because that interpreter may be from a different clan than they are, and maybe from a very close cultural community in Seattle, and therefore they don't want the interpreter to know about their business. It's very important to be sensitive to meeting the needs of patients in order to be able to communicate with them effectively. And as we've seen in terms of nonverbal communication, patience, kindness, respect, demonstrating an interest in understanding the culture of the patient, and learning about etiquette and greeting are important. Trust is a huge issue for many refugees. They may have come from countries where they were unable to trust anybody in authority in their war-torn country. They may have come from refugee camps where authority figures were abusive in many ways. So it goes without saying there should be no racism, prejudice, or bias. But beyond that, the patient must feel valued and understood. And as I've mentioned, authority figures may have been abusive, and you need to be careful with what you ask patients and how you come across to them. Relationship is built through good communication and trust. Thinking about relationship with patients and how to build good relationships, I'm going to look at an example of an approach to treating patients from other countries. And for this example, we're going to use Cambodia, beautiful country that I haven't yet been to. Cambodia gained independence from France in 1953, and Prince Sihanouk ruled as an autocracy until General Nol came into power with a military government backed by the US in 1970. As a reaction to military rule, the Khmer Rouge grew in strength from 1970 to 1975. And in 1975, the Khmer Rouge under Pol Pot overthrew Nol and abolished the monarchy. The new regime began to systematically eliminate much of the Cambodian population in what is known as the Reign of Terror. During the Super Great Leap Forward, approximately 2 million were eliminated. Hundreds of thousands were executed. Others died of disease and starvation. This was approximately 25% of the Cambodian population that died. This has been called the history of a nightmare. And so we have images like the lines of skulls from this period. Many Cambodians fled to refugee camps, and in 1979 the Vietnamese ousted the Khmer Rouge. Over the years, the United States has accepted over 180,000 Cambodians. that Cambodians have come in three groups. In 1975, government officials and professional people were evacuated, and some came to America. In 1979, we have many refugees from Thai camps who came to America, and these were Cambodians mainly from rural Cambodia. Since 1980, we've had a mixture of urban and rural Cambodians who have come as refugees. Some faces from Cambodia. I'd like to do a brief case presentation to illustrate some of the points I've talked about. I had been seeing Mrs. N in clinic for several years, treating her for depression. I'd done a full evaluation when I first started seeing her, and she had never complained of any PTSD symptoms at that time or over the years that I'd been treating her. She then came to clinic one day with a set of new symptoms, including nightmares, anxiety, and startling easily. And I wondered, how did she suddenly develop PTSD? Well, it turned out that a few weeks prior to her appointment with me, she had had a minor car accident in which they had been rear-ended. And since that time, she had started experiencing these PTSD symptoms. This was a patient who I'd been seeing for many years, and so fortunately I had a good relationship with her, and we were able to talk a little bit more about her past history and discovered that she had actually had PTSD symptoms in the past, but she had tried to put them behind her, as she said, and move forward. And so she had tried not to dwell on them and complain about any of the PTSD symptoms, and had actually done a pretty good job of repressing these symptoms over the years. However, the motor vehicle accident had triggered her PTSD. We talked about what PTSD is and how it manifests in the body, and we talked about how we were going to treat these new symptoms. And her husband always accompanied her to her appointments. And just before the end of the appointment, she said that there was one more thing that was bothering her. And she started to describe waking up, but being paralyzed on awakening in the morning. Her husband turned to her and said, "Don't bother the doctor with that sort of thing, it's Cambodian stuff." And I looked at her and said, "No, I really want to hear about this. It's important, and I want to know what symptoms you're experiencing early in the morning like that." And she described what has come to be known as ghost sickness. It is well described by the Hinton brothers, and it's a sleep paralysis that is associated with PTSD, in which many patients experience this feeling of waking up but not being able to move, and they have hallucinations in which they feel that they may be choked, or they feel a spirit coming towards them. And for my patient, she had the experience of a man coming towards her and trying to strangle her. This symptom was very frightening for her. And fortunately, I had read the Hinton article 2 weeks prior to seeing this patient, and so I had some idea of this phenomenon that is more common in Cambodians with PTSD than we see in other population groups. And so I was able to relate to the patient what I thought was happening, and this was quite reassuring to her. In terms of treatment, we added praises into her treatment regimen, and she had full resolution of her nightmares, including the ghost sickness nightmares. This case illustrates how important it is to have some knowledge of cultural background to understand the context of the PTSD symptoms that this patient was experiencing. The importance of having a trusting relationship which enables her to feel comfortable enough to share her symptoms. And I don't expect that people will know about culture-specific syndromes in detail, because there are so many patients that we treat from different cultures. But in this case, it was a bonus that I did understand what she was describing to me. The case also illustrates how to practice culturally sensitive care at an individual level. Just following on a little bit from this case and thinking about connection. As I said, I know it's not always possible to gain knowledge and background ahead of time in order to increase the chance of connection with a patient. But as we gain cultural awareness and sensitivity, I think we gain an openness to unexpected chances of connection. Another little case to illustrate this, I was working with a Somali elder in Seattle, and he had been into clinic a few times to see me and had described symptoms of PTSD and depression, and had been quite reluctant to open up about anything that had happened in Somalia during the war and the origin of his PTSD symptoms. I quite understood his reluctance to do this, since he didn't really know me at all, and decided just to give him the space and time until he was ready to do this. One day we were working with an interpreter that knew me well, and my patient started talking about the jinn very tentatively. And he looked at the interpreter, and I could see that he was trying to get some indication from the interpreter whether it was okay to talk about the jinn. Now, the jinn in Somali culture is an evil spirit that can be put upon a person. And the interpreter looked at him and said, "It's okay. This doctor is from Africa. She knows all about the jinn." And the patient turned to me, and in that moment I felt this connection with this patient that was very profound, and we have been able to really build on that connection in our relationship as I have worked with him on his symptoms of PTSD and depression. And so there was this openness that allowed that cultural connection and bonding to happen at that point during the interview. And I was very grateful for that. At a group practice level, thinking about what counts to patients, access to services is very important. Patients say how important it is to get reminder phone calls that are in their language, and so that they can understand the person who's reminding of them of their appointment. And just a note, it's important to remember that in many cultures, the calendar is different in other cultures from our calendar. And so patients may have a hard time remembering to come to appointments because of this fact. Continuity of care is very important for all patients, I think, but particularly for refugees and immigrants who have such a lot of trouble with building up trust, as we've discussed. It's important to have respect for patients, right from when they're greeted at the front desk to being taken back into an exam room and then during the clinical encounter. Looking at what counts at an institutional level, support of programs like the House Calls program that I described previously is important. And interpreter services is a very important department in a hospital that is serving many refugees and immigrants. Hiring practices should try and increase the diversity in the workforce. And it's important to have cultural competence training programs. Also, institutions should have policies that ensure a fair environment for all personnel and patients. Just looking at a few of the frameworks that can be used for increasing cultural sensitivity and awareness. Firstly, the DSM-4 cultural formulation, which is way at the back of the DSM-4, I think it's in Appendix I, on page 643. So it's surprising when I find psychiatry residents and usually attendings as well that have even read it or come across it before, because it's really tucked away. But hopefully in the next version this will be nearer the front of the book. Arthur Kleinman's 8 questions and the addressing framework are other tools that can be used for increasing cultural sensitivity and awareness. The cultural formulation, as I mentioned, can be really useful, and it looks at the cultural identity of an individual, cultural explanations of illness, thirdly, it looks at cultural factors related to psychosocial environment and level of functioning. Fourthly, it looks at cultural elements of the individual-clinician relationship. And then it looks at the overall cultural assessment for diagnosis and care of a patient. Anne Fadiman used Arthur Kleinman's 8 questions in her book, When the Spirit Catches You and You Fall Down. And it was a really nice way to use these questions to explore the cultural elements in that book. And if you haven't read it, I think it's well worth reading. Pamela Hayes has a book called Addressing Cultural Sensitivity in Clinical Practice. And her framework, called the Addressing Framework, offers another system for organizing and addressing cultural influences in the form of an acronym. So in conclusion, providing culturally competent care leads to improved patient-provider relationships and communication, and this in turn leads to enhanced healthcare outcomes and reduced disparities. How do we make a difference? To end with a quote by Walt Whitman: "We convince by our presence." Thank you.